Hi guys, this is my first recording for my reflections for ANP 8008. I'm wanting to talk about a case that I had recently through that I'm reflecting on. So I had a 26-year-old male present to the UCU with concern of chest wall pain post blunt force trauma sustained in a local footy match. He was brought in by his partner in a private car, and on the field the medic had already braced his left side with a towel, and that was giving him comfort. He had 8 out of 10 pain and he had tachypnea. The mechanism of injury was in the scrum. On the third part of the game, he jumped, and when he jumped, a knee hit him in the left side of the chest and knocked him backwards onto the ground, where he felt a little bit winded, and when he hopped up he felt a pop. He denies any loss of consciousness and has full recall of the events, nil head strike, and it was a witnessed fall. So with that information of blunt force trauma and the increased respiratory distress and heart rate, I'm querying pneumothorax. I've given him a Cat 2. I've noticed that I can see no tracheal deviation, although that is a late sign, and I need to assess him properly, but at the moment there's no obvious unequal movements of his chest. So I've rung up the doctor while I'm getting the patient into the cubicle, and I've said, hey, I've got this, and repeat my spiel using the ISBA handover. Could you please come in within the next 10 minutes to review him? The doctor then asked about his pain being 8 out of 10, and I was able to get the nurse that was working with another patient to come in and listen to the telephone order to give him some endone stat. We checked that there was no allergies, and by having 2 people there, it was part of the Drugs, Poisons and Controlled Substances Act of 1981, and the 2017 regulations were followed. We got the endone and made sure that was given quickly, but we first did our primary survey. His airway was patent. His breathing, although his rest rate was 26, it was short and shallow, and he was speaking in full sentences. His circulation was pink. He was quite sweaty, but he had just come straight from the match, and his central cap refill was 2 seconds. He was alert and guarding his side, and we actually got him to take off his football jersey, popped a warm blanket around his shoulders, and assisted him to get the splint back in again so we could have a good look at him. I follow Ample, so I asked about past medical history as well. He had shin splints and ADHD. The medications, or the only medications he was taking, was Ritalin, and socially he is a footy player from the next town over, who is also a private contractor. So I moved on to the secondary survey, and that included the CNS. So with the Glasgow Coma Scale, we rated him as I rated him as 15, with his eyes 4, voice 5 and movement 6. He had neo altered sensation or strength in his limbs. His mobility was good. He was able to take his jersey off normally. I watched him walk in. His pupils were equal and reactive to light, and they were 2+ in both eyes. When I did his blood pressure as part of the CVS system, I noticed it was elevated and he was tachycardic, but that is also probably attributed to pain and the stress of the situation. I did report that to the doctor when I gave the ISBA handover though. I had put a SATS probe on him just to monitor his SATS because I was worried about the risk of a pneumothorax because of the blunt force trauma. But his SATS remained above 98%. He had short, shallow breaths with his shoulders up, very guarding. He had what looked to be equal rise and fall of his chest, and I auscultated and I could hear good air entry into both the apex and bases of both his lungs. On examination, I noticed with inspection that there was no bruises or deformity or hemorrhage or obvious marks on the skin. When I looked at it, I assessed that there was no creps. Then I palpated his ribs, and I noted that on the left chest wall there was marked pain on the 6th, 7th and 8th rib, more lateral, but there was no step down. There was, it still felt intact. And by that time, our on-call doctor had turned up, and he is credentialed to do X-ray. So he used the appropriate treatment to see if there was a pneumothorax. It's not something that we would use to see a defined fracture with the ribs, because that quite often is unlikely, but we're wanting to look for any changes in the pleuritic space that we can see on X-ray, and we do that standing up for our patients so we can get a better view. I did reflect, and I could have actually put a cervical collar because he had jumped and fallen back. And I think maybe that's a learning point for me when I was going through the PCCM's HMC on page 164 for traumatic injuries. I noticed that it's probably a little hole, it probably is a hole in my practice that I can think about next time, which is really great. I also noted that I didn't, although the family were there, I could have talked to the family more. So in the end, what we did with this gentleman was we made sure he had enough analgesia because he was in significant pain. So a script was written up for Panadine Fort. There was the X-ray still to be reported on, which was linked to his GP, so his GP and him could have a consultation early next week. So this happened on a Saturday football match, so probably Monday or Tuesday we recommended him going in and seeing his GP and getting the formal X-ray results and follow up. We did advise that it's going to be really sore for him, and we treat it like a fracture even if we can't see a fracture. I gave him a patient handout on the importance of deep breathing and coughing exercises to prevent complications from this injury and to prevent pneumonia. We made sure there was because of his social work commitments, we made sure that he had work cover. So we did a medical certificate to assist with that, which is something that him and his partner were concerned about. And then we gave him a lot of encouragement to come back to UCU if he has any questions or concerns, or he's starting to get worse with his symptoms. By this time in our assessment, the patient's shortness of breath had really decreased due to the analgesia. He was feeling much better. I think his anxiety levels had probably dropped with knowing what was going on and why this was happening to him. And he was happy to return to the UCU if he noticed increased issues with his breathing, if there was any concerns whatsoever. Yep, so thank you so much.